Greetings, everyone. My name is Ahmed. I'm a general surgery resident at University Hospital's Cleveland Medical Center Case Western Reserve University program, and I had the honor of working with the thoracic surgery department at UHCMC in conducting the study. The robotic minimally invasive esophagectomy provides superior surgical resection, and we have had the honor of presenting it to you guys as sages today. I have no disclosures. A little bit of background information. Esophageal cancer is the 9th most common cancer and the 6th most common cause of cancer deaths worldwide. Despite advances in chemotherapy and radiation, esophagectomy remains the mainstay of multimodal treatment approach for esophageal cancer. And in comparison to the traditional open esophagectomy approach, the traditional minimally invasive esophagectomy approach has actually been associated with lower in-hospital mortality, fewer surgical site infections, and shorter length of stay with similar long-term oncological outcomes. However, there's very limited data comparing the difference in outcomes between robotic minimally invasive esophagectomies and traditional minimally invasive esophagectomies, which is what we tried to look at in our study. So we conducted a retrospective cohort study in which we queried the National Cancer Database for patients undergoing robotic minimally invasive esophagectomies and traditional minimally invasive esophagectomies from the years 2010 to 2016. The robotic cohort was defined as procedures that started robotically. The traditional cohort was defined as procedures that started thoracoscopically/laparoscopically. Primary outcome was 90-day mortality, and our secondary outcomes that we looked at were positive surgical margin rate, number of lymph nodes removed, length of stay, readmission rate, and conversion to open rate. Statistical analysis was made up of bivariate comparison of the two cohorts by operative approach. Rank sum test and chi-square testing is appropriate, and multivariable regression testing of independent association of the procedure approach on certain outcome variables. Overall, we evaluated a little bit over 6,600 minimally invasive esophagectomies over those 6 years. Of those, a little over 1,500 were robotic, and a little over 5,000 were traditional approach. 90-day mortality was similar between the two groups. The real differences that we saw were in surgical margin, lymph nodes evaluated, conversion to open, and length of stay, in which the robotic cohort was actually found to be superior in lower rate of positive surgical margin, higher lymph nodes evaluated, less likely to undergo conversion to open, and having a shorter mean length of stay. And if you look at this, which we're going to discuss this in further detail later, the difference in positive surgical margin and likely to undergo conversion to open was actually pretty steep, with almost pretty much double. And although the difference between lymph nodes evaluated and length of stay in the between the two cohorts was modest, it is still statistically significant, and those two play important roles when it comes to esophagectomies and esophageal cancers, and even the slightest difference, we believe, is of importance, which we'll discuss later. In comparing the two cohorts, there's really no statistically significant difference between age, gender, insurance type, or tumor size. The traditional cohort had higher Charlson-Deo scores, whereas the robotic cohort was more likely to occur at academic institutions, had higher clinical T and N staging, and had higher rates of perioperative radiation and chemotherapy. In multivariate analysis, comparing 90-day mortality between the two cohorts, again, there's no statistical significance. And a trend that we found interesting in analyzing the data is over the 6-year time span that we looked at, the proportion of robotic minimally invasive esophagectomies increased significantly from 10.3% to 27.2% over the 6 years, which we find to be very interesting. In comparing the two cohorts again, no difference in 90-day mortality, no difference in hospital readmission. Again, the differences noted here are at positive margin rate, lymph nodes evaluated, and length of stay. And again, the robotic cohort came out superior in those three categories, especially in the positive margin rate. And although there's a modest difference between the lymph nodes evaluated and length of stay, we will discuss later why that's still important. In multivariate analysis, looking at positive surgical margin rate and conversion to open, again, statistically significant difference between the two cohorts, with robotic approach proving to be superior. Again, comparing length of stay here between the two cohorts in a multivariate analysis, again, going to show statistically significant difference between the two cohorts, where robotic, again, is superior in that outcome with shorter length of stays. And here we looked at multivariate analysis of obtaining adequate lymphadenectomy, which is defined as greater than 15 lymph nodes between the two cohorts, in which, again, the robotic cohort was superior, and this was statistically significant. So to summarize, when compared to the traditional minimally invasive cohort, the robotic cohort came out superior in regards to number of lymph nodes resected, lower positive margin rates, and lower conversion to open rates. And this was seen both in univariate and multivariable analysis, and was statistically significant in both. Similar results regarding lymphadenectomies are actually seen in propensity match studies done by Yang and Deng and colleagues. And the reason the difference in lymphadenectomy is so important is it plays a very significant role in defining stage, prognosis, and survival in esophageal cancer and patients undergoing esophagectomies. And giving the superiority of the robotic approach in this study when it comes to lymphadenectomy, this suggests a major benefit to this approach when it comes to this operation. Although the traditional approach has shown excellent outcomes compared to the open approach, it does have its limitations, which include two-dimensional viewing, limited dexterity with movements given the nature of the instruments used, and suboptimal ergonomics. And these are addressed with the robotic approach, which offers three-dimensional viewing, self-controlled magnifying viewing, instrumentation with 7 degrees of freedom, and tremor filtering capacity, which allows for more meticulous and precise dissection. However, with every approach comes downsides, and with the robotic approach, we see longer operating times, steep learning curves, and significant costs that have been discussed in other studies. Limitations to our study include, which most importantly, we do not have access to the technical details of the surgical procedures, as this is not available in the National Cancer Database, so we cannot comment about that. Again, this was a retrospective review, and unmeasured variables can confound our analysis. However, we tried to limit that effect by using multivariable regression. Just as with any operation, experiences can affect surgical resection and outcome, and especially when it comes to this operation, as it is a complex operation, and when you start adding factors as minimally invasive and robotic, there is a complex relationship between learning curve and case volume, which can also confound findings. And then other variables that can affect outcomes are recovery pathways that may exist at certain institutions, which can affect length of stay, and the differences in pathological evaluation, which can occur at different institutions, which can affect positive margin rates and lymph node rates. That is the conclusion of our study today. These are our references. Thank you again for the opportunity to present our studies at SAGES, and please let us know if you have any questions.